Hello, and thank you for joining us today for our webinar, The Promise and Challenges of Multi-Cancer Early Detection Tools. Thank you for joining us on Election Day. I know it's a very busy day. We thought we'd give you something to distract you from looking at the news, if you're inclined to do that. So we are happy to have you join us for this important discussion about emerging technologies that could change how we approach cancer screening and detection. We're grateful to Exact Sciences for sponsoring this webinar. We're not going to be talking about specific tools or tests, but really rather kind of looking at the landscape and what are the promise and challenges. We're fortunate to have two distinguished speakers who will help us examine this topic from complementary perspectives. Dr. Otis Brawley from Johns Hopkins University brings his extensive experience in oncology, epidemiology, and public health to help us understand the scientific and clinical implications of multi-cancer early detection tools. And importantly to us, he is a member of the NCCS Board of Directors, and we're really grateful to you, Otis, for joining us today. And he'll talk about the research questions and help us frame how these emerging technologies may fit into our broader cancer screening strategies. And joining Dr. Brawley is Stacey Tinianov, a cancer survivor and passionate patient advocate who serves as Executive Director of Advocates for Collaborative Education. Stacey will provide crucial insights into how these screening advances could impact patients and their families, bringing the essential patient perspective to this conversation. We stand at an interesting crossroads in cancer detection. While traditional screening methods have served us well for certain cancers, we do not have screening for many types of cancer. The emergence of multi-cancer early detection tools presents new opportunities and new questions. Today's discussion will explore both the promise and the challenges we must thoughtfully address as we consider whether and when they could be integrated into clinical practice. Throughout the conversation, please ask your questions in the chat, and we hope to have a very interactive discussion. So we're going to start with Stacey kind of laying the groundwork for us because there's a lot of confusion about different tests. We know that cancer patients have many different tests that they take throughout their treatment. And so she's going to just explain what we're talking about when we talk about multi-cancer early detection tools and explain what we are going to discuss today and what we're not talking about today. So I'll turn it over to you, Stacey.
Thank you, Shelley, and thank you to NCCS for hosting this conversation and for inviting me, and thank you to Dr. Brawley for participating with me in the dialogue. So I know that many of you on the call are familiar with the term liquid biopsy, and multi-cancer early detections, or MCEDs, are a form of liquid biopsy, but they're all not the same. So what we're going to talk about today is really the multi-cancer, so not just the one you're at risk for necessarily, or not just one that you had before, but any cancer early detection test. Sometimes they take the E out of it, so you might see multi-cancer detection tests. Again, it's a type of liquid biopsy, so it's through the blood. And this is used really in the screening context. So these are in asymptomatic individuals, people who do not, have any other reason to be tested for cancer, just to see if they have cancer signals. It is not used for prediction or measuring treatment response that some of you, if you're in the patient space, maybe have participated in. It is not used for resistance detection. So if you're on a medication and you may have developed a resistance to it, this is not what this test is for. And it's not used in a monitoring to test for recurrence or metastases or any sort of surveillance. So again, as we have the conversation, I just want to make sure that everybody's very clear on the fact that we're talking about the multi-cancer early detection piece of it.
Great. Thank you, Stacey. So now that's the only slide we're going to have. We're just really going to have a conversation. So I'm going to turn it to you, Otis, first to kind of share your thoughts about where we are and what we need to be thinking about as we learn about these tests. Oh, you're muted.
Thank you very much. It's a privilege to be here. And Stacey, please call me Otis, no Dr. Brawley, okay? The multi-cancer early detection tests, there are about 40 of them right now out in the real world. And many of us, by the way, have consulted for companies that are developing these. Some of them are actually sold. And they're not FDA approved yet, so they can only be sold through unique mechanisms, which we call the home brew law, which says that if you make a test up and you are providing that test from your laboratory and samples are sent to your laboratory to be analyzed, you can analyze the sample and give someone an answer, but you have to tell them that this is not an FDA approved test. The FDA approves tests for screening when there's evidence that it prevents people from dying. And these tests right now are in the process of being evaluated to see if they do that. Now, Stacey and I actually think that tests should be approved if they improve the quality of life of an individual or if they prevent someone from dying. But the FDA, by regulation right now, requires proof that someone does not die because they get the test. Now, the tests that, and I should point out, early detection can be broken down into screening, which, as Stacey said, is doing a test because someone is of a certain age and a certain sex and at risk for the test. If I do a mammogram because a woman is 45 and she has a normal physical exam, that's a screening test. If I feel a mass in her breast, I do the mammogram, it's actually considered diagnostic and not screening, and it's even billed differently, even though it can be the exact same test as the screening test. Also, if I have someone who's at high risk because they've had the cancer before, I may do a mammogram. That's actually called surveillance. But these are actually tests that are being used for screening. These are being used to diagnose a cancer in someone who's never been diagnosed before. Now, when I talk about FDA approval, we have approvals in FDA for screening for cervical cancer using pap smear or testing for HPV infection, human papillomavirus infection. Stool blood testing, stool DNA, and colonoscopy have been FDA approved for colon cancer. Mammography for breast cancer, not ultrasound, not heat sensing technology, but mammography has been approved for breast cancer screening. Lung cancer screening with spiral CT, low-dose spiral CT. Now, there's screening out there that's frequently done that is not FDA approved. The most common of that is prostate cancer screening with the PSA. PSA, or prostate-specific antigen, has been FDA approved for evaluation of men who have symptoms. Ironically, it is not FDA approved for its most common use, which is screening. Thyroid screening with ultrasound, skin cancer screening again, and endometrial screening are all done, but they're not FDA approved. Now, with MCEDs, or multi-cancer early detection tests, these are blood tests. People give about 80 cc's of blood usually. It's a few tubes of blood, maybe 4 red top tubes of blood. The blood is sent off to a laboratory. It is analyzed looking for fragments of DNA in the serum, sometimes looking for other chemical changes like methylation of the DNA in the serum. And people will sometimes get back an answer. In the worst case scenario, the doctor says to the patient, I have bad news, I have good news, and I have really bad news. The bad news is there's a cancer signal here. The really bad news is, or the good news is we found the cancer early, and the really bad news is we don't know where the signal is coming from. These multi-cancer early detection tests have been positive from a number of different organs. Now, sometimes you will get someone who has this test and it's positive, and we have a good outcome or a good finding. But sometimes you'll have the positive test, but you don't know what to do with the information. And there are a number of people who've been in studies looking at MCEDs who end up very, very confused and in a state of emotional turmoil because they're told we've got a cancer signal and we don't know what to do about it. These sometimes cancer signals can be false. Sometimes they're true, and the tumor is just so small, it's not findable through any kind of CT or MRI or PET scan. And sometimes the tumor is a true cancer, but it's what we call an overdiagnosis cancer. It's the kind that we frequently talk about in prostate cancer that is not genomically yes, it is cancer. It is cancer, but it is not genomically programmed to grow, spread, and kill. And indeed, in prostate cancer, thyroid cancer, kidney cancer, we actually know, and we have more and more molecular tests that try to help us figure out the cancers that we should watch because they don't need to be treated versus the cancers that need to be treated. That's actually another area of science that's in fast development to figure out molecular estimates of the carcinogenicity of a cancer or the malignant potential of a cancer. And so I'll stop at that point. Stacey, you want to add some things?
I think you covered it. I think when we think about screening and we think about early detection in a healthy population and a population that really hasn't either been personally or kind of with their friend circle or family circle been afflicted by cancer, there's this very common saying that early detection saves lives. And I think a lot of it originated from kind of the mode of FDA approval that really, on a population basis, not on an individual basis, it had to be proven that screening did in fact reduce mortality. But when we talk about these tests, we're talking only about identification. And so we are identifying, I talk with my hands a lot, but micro, fragments of DNA, fragments of tumor cells to show that there's something going on in the body. And it's great in the sense of, okay, now you have more data, but the very next question is, what are we going to do about it, right? The first thing you have to do is you have to verify, you have to validate that this cancer actually exists, right? So you then get thrown into the oncological world of diagnostic testing, right? Now we have to go through and we say, okay, do we do imaging? What do we do? And then you have to have something that is significant enough to actually be found in that way and be treated. So, again, on a population level, that's how things get approved. On the N of 1 level, this is a test for me, this is a test for my friend, my daughter. If it works, I would get really excited about it. And at the same time, I really want the general public to understand that this is not, first of all, to replace any of the current validated screening mechanisms that we do have in place, and we do know what we're doing with. And two, we still don't know what we don't know. And
Yes.
so just because you get a signal that there's something going on in your body, we may not be able to do anything about it. And personally, I could go both ways. Having a history of cancer, I think at this point I want to know. Before that, I think if there's nothing I can do about it, I would kind of feel like I was tied down to a railroad track with the train coming and I didn't know how to get off. So,
Yeah.
Yeah, go ahead.
Yeah, you bring up so many important points, Stacey. The fact that we don't know so many things, the fact that how we figure out if screening actually works is more of a public health issue. And, I know I have all the answers when we're talking about 1,000 people. I have none of the answers when we're talking about the patient in front of
Yep.
me. Perhaps I can give some examples of how just finding the cancer is not necessarily beneficial to the patient who we found the cancer in. In the 1960s, there were randomized studies at the Mayo Clinic and elsewhere looking at chest x-ray screening, where a group of people got chest x-ray screening and a group of people did not. This is primarily smokers, but this was just at the time when we're starting to learn that smoking caused lung cancer. It ultimately showed that the death rate amongst people who got screened was 3.2 deaths per 1,000 per year. And the death rate among people who did not get screened was 2.8 per 1,000 per year. Now, the people who got screened had longer survival from lung cancer if they were diagnosed with lung cancer. The people who did not get screened had shorter survival, but the people who did not get screened were less likely to die from lung cancer or procedures to diagnose and treat lung cancer. And so from the 1960s until the early 2000s, we actually recommended against screening for lung cancer because we had a randomized gold standard trial that showed us that the large group of people who would be screened would be worse off than the group of people not screened. There was a similar study, by the way, looking at urine VMA testing for neuroblastoma, which is a childhood tumor this was done in Canada and Japan, by the way, where they figured out that screening young kids for neuroblastoma was net harmful rather than helpful. Now,
Yeah.
let me give you some real numbers. I hate to turn into numbers, but this is important. The reason why we recommend lung cancer screening for people at high risk for lung cancer is a randomized study of 54,000 people who had a smoking history was done. These were people over 50 with an extensive smoking history. And 27,000 got screened with low-dose spiral CT. 27,000 got a chest x-ray. That what was shown was of the people who got spiral CT, after 10 years, there were 350 who had died of lung cancer. Of the people who got what was really a sham chest x-ray, there were actually 437, 87 difference. 20% relative risk decrease in death among people screened is that 87 difference. 437 in the 27,000 who didn't get screened, 350 deaths in the 27,000 who did get screened. First thing I want to point out is 350 of the people who got the good test still died of lung cancer. It's just 20% less died of lung cancer. The other thing about that study, and this is New England Journal 2012, this is the reason why lung cancer screening is out there now, is that study demonstrated that the lung cancer screening saved 87 lives, but actually caused medical instrumentation and diagnostics that kill 16. And so we in the professional screening world think of lung cancer screening as something for every 5.4 lives that it saves, we sacrifice one life. This is the good of screening and the bad of screening. And this is at population level. And by the way, this is the reason why Medicare says it will pay for lung cancer screening amongst people eligible if Medicare is also charged for a 1 hour conversation where a healthcare provider tells the patient the good and the bad of lung cancer screening so the patient can make a decision if they want it or not.
So it's so interesting that you just brought that up. And I was just looking at the comments and Carol said the emotional impact of a maybe cancer diagnosis needs to be understood. And that is the perfect way to say it. This needs to be, and I hope part of this conversation leaves people with the idea that fully informed consent needs to be a thing. And what these tests are capable of doing from a scientific standpoint, from a innovation standpoint, this is phenomenal. This is absolutely phenomenal. I'm all in. However, we still don't know what we don't know. And does that mean I don't think people should participate at all? No. But do I feel like we need to have some scientific rigor around determining, again, these are going to give you signals, right? That's what we say. We say these tests give signals, and you've got cancer signals or you don't have signals. But our body kind of messes up on a regular basis, right? There's fragments of cancer in everybody's body on the daily. And we need to figure out, those thresholds need to be determined. When has something kind of gone rogue, and now there's a threshold that's large enough that we know that this is actually formed a solid tumor, and we need to do something about it, right? The other thing, and again, I know whoever's on the call, some of you are probably well aware of the idea of cell fragments and fragmentation, and kind of tumor cells going around. Not every tumor is a shedding tumor. And so the other really, really, really detrimental thing that we need to be aware of is people getting this false negative. People who may have something going on, and may not opt for traditional screening because this is easier to donate a little bit of blood. If they happen to have a cancer, and this is known, this is not just with MCEDs, this is with every liquid biopsy. So this is not about this particular application. There's just some tumors that don't shed. And so again, we need to look at what's the benefit going to be, but then that risk, as Otis was saying, to know that something's going on and not be able to do something about it, or to think that something's going on and go through the battery of diagnostic tests to confirm it when maybe nothing really was going on, right? And we deal with this a lot in the breast cancer space, right? People go in, there's some level of anomaly, and they then go in for a biopsy. And there's the anxiety, there's the physical, issues, related to biopsy, and then it's a big fat nothing, right? But again, Carol, you phrased it so appropriately, and the really, truly, fully informed consent, I think, is something that we need to think about.
Yeah. I am very optimistic about these MCEDs in the future, but we need to do the tests so I can give you numbers the way I gave you numbers with low-dose spiral CT. And we need to know what is the false positive rate where the test says there's a cancer and ultimately there is not a cancer. What's the false negative rate where the test says there's no cancer, but in reality there is? And something you said, Stacey, I just want to reiterate. I don't know of a single company that's developing these tests right now that says that this test ought to be standalone and people not get the regular tests that have been recommended. 60% of women over the age of 50 are getting regular, routine, high quality mammography. I don't even know what the percentage is of women over 45 because, by the way, all of us, be it the American Cancer Society, the U.S. Preventive Services Task Force, the Canadian Task Force on the Periodic Health Exam, everybody recommends routine high-quality screening starting at age 45 for women. And again, I just said 60% of women 50 and above get it regularly and routinely. We have a problem with pap smears. Or I shouldn't say pap smears, cervical screening, because now we can do HPV screening. There's 4,000 women who die from cervical cancer every year in the United States. Now, that is a screening test where almost all of those women, their lives could have been saved if they had been screened within the last, say, 5 to 10 years earlier. And we've got good data to show that there's women who don't get cervical screening who should. There's about 60% of people over 45 who are up to date in colorectal cancer screening. These are all tests that we know save lives, yet
And we've worked hard. We've worked hard as advocates to push these validated screening tools. We've
yes,
really worked hard. It is not an easy sell. And you know, Allison Rosen, who I don't think is on the call, but man, that woman talks about get your rear in gear and get the camera up your
yeah,
bum.
yeah,
And with colorectal screening, again, many of you probably already know this, but people misrepresent mammograms and say prevent breast cancer, get a mammogram. Mammograms do not, will not, have not ever prevented breast cancer. However, you have a colonoscopy, they find a polyp, they cut it off, you have actually done primary prevention of colon cancer. And I think the fear in some of the advocacy circles is if a screening test is a little bit challenging, like you have to have a camera up your bum, people are going to
yeah,
instead opt for this thing that feels
yeah.
easy. And the fear is, yes, it might be easier, but it may not be as accurate or as valuable or as
Mhm.
good.
Yeah. Well, now I'll tell you, in colorectal cancer, we have great numbers. By the way, the recommendation is stool blood testing every year, stool DNA testing every 3 years, or colonoscopy every 10 years. And we have great numbers. Let me give you the numbers from the stool blood testing study. The University of Minnesota started this back in the late 1970s. If you had a positive stool blood test, you want a colonoscopy. And for people who just get stool blood testing every year, and if it's positive, go to colonoscopy, those people after about 15 years have a 33% decrease in colorectal cancer death rate. It goes down by a third. And they have a 20% decrease in colon cancer incidence. So, stool blood testing actually is linked to lowering the incidence of colorectal cancer. Now those people who have positive stool blood tests then had to get the colonoscopy to remove the polyps. But the reason why this is important, by the way, is when we make these public health recommendations, and there were some people who wanted a recommendation for only colonoscopy, and cooler heads prevail. There are about 20 states in the United States that don't have enough GI docs to do a colonoscopy every 10 years on everybody over the age of 45. For those states, thank goodness stool blood testing or stool DNA works. Even in Maryland, where I live, there are people who need to drive 2 to 3 hours to get to a GI doc who can do a colonoscopy. For them, stool blood testing or stool DNA, and then if it's positive, making that drive for the colonoscopy makes a lot more sense.
Yeah.
So one of the questions actually was, is there a thought of using these MCED tests to determine people who are at higher or lower risk to go on to have more invasive or frequent screening? So could they be used to determine other screening that needs to be done?
That is a different type of test that should be used for that. And that should be done in combination with a conversation with a genetic counselor. And the genetic counselors, by talking to people and getting their family history, are oftentimes very good just by mapping the family history at saying this is likely to be someone who has a BRCA mutation, or this is likely to be someone with a PALB2 mutation or an ATM mutation, and that sort of thing. Now, that's another question. Should we have sequencing of everybody's blood to see if they're at higher risk for various cancers? I'm a little worried about that. By the way, there's some insurability issues related to that as well. In the Affordable Care Act, if you have a history of breast cancer, you cannot be denied health insurance. But if you have a known BRCA mutation, you can still be denied life insurance.
Yeah. Gina only protects the health insurance pieces. Absolutely.
Being the genetic information, not,
Sorry. Yes.
yeah,
Yes.
sorry. Okay.
Non-discrimination Act.
Uh,
It's interesting too. You talk about, risk and high risk. And I would say, again, a blood test is an easy button. And if everybody on this call hasn't already had the conversations with family members about health history, that's a really good place to start. And actually, those conversations sometimes can be even more insightful than trying to get in line for genetic counseling if there's no indication.
Yeah. But doctors, by and large, don't understand as much about genetic risk as genetic counselors, which is why I try to encourage people to spend the 1 hour talking to a genetic counselor if you can. Now, there is a problem that there's a shortage of genetic counselors around the country.
There's a question, and I want to answer it. And Veronica, I'm sorry, I know you said you'd field them, but I saw it. Can I answer?
Yeah.
Somebody asked, if these are not ready for prime time, what's the responsibility of these companies that are promoting them? And I think one of the things that people need to be aware of is some things are promoted, not promoted, some things are made available to medical professionals, right? And so it's a test that they order, that they decide based on guidelines, based on the person in front of them, whether or not to order. Um, Tests that go directly to consumers, tests that if you have an extra $700, $1,500, $9,000, whatever it is, those can be marketed and are being in many cases marketed directly to individuals. And so this is more a conversation around knowing what you're getting into, right? You can find multi-cancer early detection tests available now as an individual. But what you end up with is information then that is not going to go to an oncologist, right? Most of us on this call are affiliated with oncology. These are tests that are available and marketed to, based on the role that they are trying to play, to a healthy asymptomatic population. And so we meaning our healthcare system does not have an operational process to consume this right now, right? So if you have a test that says you have a signal, where are you going to bring that? You're going to bring it to your primary care doctor because that's the relationship that you have. So even if these tests were wonderful, and again, I agree with Otis, they will one day be wonderful, but I still think there's a lot to prove out. We need to help educate the MD, the medical professional that then will see this test and kind of know what to do. So if you've known me for half a minute, I talk often about the systems-based approach, right? This is not a problem for oncology to solve by itself. This is not a problem for advocacy to solve by itself. And this is not a problem for all of these brilliant minds making these tests to solve by itself. It really needs to be a conversation about, do we have something that's going to provide valuable information and trustable information? And then what are the intersection points so that we can get the person with these results in the right flow, in the right clinic to confirm, to treat, to support that.
Yeah.
And again,
So I've talked with people from several of the companies that make these tests, and one of the things they're definitely thinking about is, this is going to happen through, ideally, this would happen through primary care. And then we have to have that process of navigating somebody once they get a test result to determine what the next steps are. And I wonder if, Otis, if you could talk, if in the clinical trials that are being done, like how are they doing that?
Sure.
You talked earlier about sometimes there's actionable data and sometimes there's not. Do you have a sense of
Mhm.
how often the data really is actionable versus it's a signal that there actually isn't a recommendation on how to go forward.
Yeah, yeah. And by the way, I people who are interested in these tests, I encourage you to seek out the clinical trials that are trying to perfect these tests. And when I say perfect, almost every one of the tests that I know out there that's offered right now is different today than it was earlier this year. These tests are actually evolving over time as they try to make them better and better. In some tests, as many as 15% of people who get a blood test will have an initial positive signal, and that positive signal, uh, usually they're going to be able to, but not always, say it appears to be endometrial, it appears to be pancreatic, it appears to be lung. They're usually able to narrow it down to one or two specific organs, and then they will want to do diagnostic tests, imaging of those organs. And for certain organs, they'll want to do a CT, for others, an MRI, sometimes the combination of the two. And for certain organs, they'll want to do a PET scan. Uh, and this is also where we get into the problem that if you just do CT scanning of people walking down the street, 1 in 8 will have an abnormality on the CT scan. If you just, you know, there, there's a large proportion of us who have something on our CT scan that the radiologist will say is not normal. And it can be a cyst, it can be old scarring from uh, inhaling mold or COVID lesions that you've had. It can be a number of other things. But if people get involved with MCEDs, they need to realize there's a high likelihood, at least 1 in 8, for some tests, that they're going to be told there's an abnormality. And of the people who have an abnormality, you're going to high likelihood need to have some imaging.
Thank you. And so the next question I wanted to ask is something that you alluded to at the beginning, Otis, when you talked about quality, that FDA is really looking at, do the tests extend life or reduce death, basically,
Yeah.
which takes a lot longer to measure for one thing. And so, but you mentioned that while it's not something that FDA looks at, it's something that's still important to measure is how it improves quality of life. How are we measuring that, or are the clinical trials currently measuring that? And what would that look like if it improved quality of life but didn't actually reduce death? Can you talk a
Yeah.
little bit more about that?
Yeah, uh, again, there are 40 plus companies out there who have these tests, and they're in various stages of development. Some are actually, the only question that they're asking right now is, does it find cancer? They're not even asking, does it find cancer early? There are others out there that are asking the question, does it find cancer early? And then there's a couple of the larger companies that are now starting to look at the question, does it stop people from dying? Uh, I don't know, Stacey, you might, of anybody who's truly looking at quality of life right now.
No, I think it's a big advocacy push. Again, we get that the FDA approves tests on does it actually reduce mortality, and at the same time, in the cancer space, if there is an early detection that allows for more treatment options, in some cases, maybe options that are less toxic for smaller cancers or less invasive cancers. We support that fully. So that's part of the advocacy push into trying to get these tests made available and approved, right? Splitting that difference.
Yeah.
I think one of the other aspects and something that we have not talked about is there are cancers where we don't have any screening at all. And I think the hardest conversations that I have are with people who are potentially, in the ovarian cancer space, or, in a space where the cancers tend to be highly deadly. And they tend to be found at a very advanced stage. Again, hoping that there are more clinical trials that kind of look at the efficacy of these tests in identifying cancer early and early enough when it can be treated.
Yeah.
But it is a very hard conversation, and this is not a black and white discussion, that these are not all great and they're not all bad, certainly. I
Yeah,
think
the other
there's
big tumor there that I would mention is pancreatic cancer, ovarian and pancreatic cancer especially. And as a professional screener, the unfortunate question that hasn't been answered about pancreatic and ovarian cancer is, are they screenable tumors? Are they tumors where early detection actually would be beneficial? And then the other question is, you need to have a test to do that early detection as well. And there is some hope that the MCEDs will be the answer to both of those questions. But again, I separate hope for what we're moving toward versus where we're at right now.
And so what's missing then in what we know now than what we need to know to be able to bring these into when these are going to be ready for prime time?
Well, it's the struggle between time. We want these tests to work now, but it's going to take time and good clinical trials to figure out if these tests truly do work. And that's a public health issue. And then, but we have patients, individuals who need these things now. And that's the struggle.
Yeah. One thing that we haven't talked about too is I think a lot of us are very focused on obviously quality, but equity. And when these tests are kind of going direct to individuals, and again, when there's not necessarily a reimbursement model based on a lack of FDA approval, the people who are going to be able to access them are the people who have money. And I just want to put that out there, that when we find something that works, it really needs to be made available to all individuals who would benefit from it.
Yeah, I'll go one step further, Stacey. The other issue is uh, if you start using healthcare in inefficient ways, and we have a hugely inefficient healthcare system as it is, you're going to crowd the CT scanners and the MRIs with people who've gotten these tests. And for my patients who are already upset that they have to wait 10 days to get to the CT scanner, the line to the CT scanner is going to get even longer.
Yep.
We may actually increase health disparities by making the lines to these diagnostic tests so long. The people who don't get them are the poor folks. Those are the folks who drop out of line. And so I do worry that inappropriate use or unwise use of unproven tests can actually increase health disparities.
Which is really the case anytime there's a new technology, right? I mean, that it increases any new, I've heard you talk about this before, that any new technology or treatment, it initially increases disparities.
Yeah, let me explain it. I was director of a cancer center in a public hospital in Atlanta when the CT scanning thing came out. We had very tight budgets, but you could take some of that uh, precious money and you could buy the new software that had to go onto your CT scanner in order to do CT screening for lung cancer. Then you had to train a radiologist to read that. And then you have the problem that in the public hospital, you have 4 CT scanners. In some of the hospitals that take Blue Cross and other things down the street, they have 7 times that many CT scanners. But you see the same number of patients. And so if you start offering CT screening in the hospital where all the poor people get, you make the line for those 4 CT scanners even longer. Whereas the hospital has got 25 to 30 CT scanners, literally, can absorb their increase in usage a little bit better. And so this is one of the ways that you end up causing more health disparities. Now, unfortunately, even though in the United States we spend 18 cents out of every dollar on healthcare, and the number 2 country spends 11 cents out of every dollar, 11% of the GDP of Switzerland or Germany versus 18% of the United States. Resources are scarce for many people in the United States.
So, are some hospitals are already using MCED tests? Are they using them outside of clinical trials or only in the context of clinical trials? And do you know when in the process, like in the patient journey, are they using them?
I am not aware of any hospital using MCED technology. Again, going back to the beginning of the presentation, talking about liquid biopsies and the kind of myriad of liquid biopsy tools that we have, people are absolutely using them, right? We are looking at liquid biopsy technology to detect response to treatment. So for instance, somebody has a diagnosis, they have neoadjuvant chemotherapy, and then we check to see whether or not there's a tumor burden that continues to exist. We know that that can predict prognosis, but we also then can say maybe we extend systemic therapy before we go into surgery, or maybe we add on adjuvant therapy after surgery. There's been a lot of work in liquid biopsies looking at resistance. Oftentimes people have a particular disease and they have a particular treatment, and that treatment works for a good long period of time, and then it stops working. And there are now treatments that we can give people that actually go after that resistance, right? The tumor biology is actually changing. The other way that we're looking at liquid biopsies in some individuals is in the metastatic population. You can get somebody to either no evidence of active disease, or in some cases no evidence of disease at all. And then we can monitor sometimes these individuals to see if something is popping up. But again, this is in a population that has already been diagnosed with cancer, that has already been treated for cancer. This is not in a otherwise, asymptomatic population.
Yeah, there are some websites that people can go to and order these tests, but even then they have to go through a physician to get a prescription. Sometimes the website will provide that physician for them. Sometimes people use their own physician. There are also some centers that are running large-scale studies to try to make these tests better. These are the clinical trials to improve the test. And that's the thing I would encourage people who are interested in this technology to go look at these clinical trials and see if you can find one that you would like. These clinical trials usually also have the added advantage that there's no cost, at least for the test itself. Now, there will be costs for the diagnostics if the test turns out to be positive.
Okay, so let's imagine that we're in the future and we've got a test that is ready for widespread use and has been determined to be helpful and reduce mortality and increase quality, or both. What would you see both from the clinical side as to what's the ideal process for how this works, and then from the patient communication side, how do we talk to patients about it and help them make an informed choice about, whether they want to have this test?
I'll
Wanna
start,
go
Stacey,
first?
and then you can. One of the things that this test might do is make us a little bit more holistic. I am so tired of people who get lung screening. This happened to me not too long ago. A woman got lung screening because she's a former smoker, and the radiologist reads out, her lungs are fine, but you do know she has stage 3 breast cancer. This is somebody who's getting lots of lung screening every year, but has not been getting breast cancer screening. We have the same thing happen with colon cancer or cervical cancer. And the Koreans have one wonderful thing. It's actually given us some very interesting findings regarding bad screening as well. But they have clinics where you go in at 9 o'clock in the morning, and by 4, you've gotten every screening test that you should get. And maybe these MCEDs, which every company that makes them right now says that their goal is that they would be an adjuvant, an adjunct to regular screening, not a replacement for regular screening. Maybe we can pull regular screening together and look at the whole patient and not forget that this woman has breasts as well as a lung and colon.
Yeah. So when you say that these are ready for prime time, I'm imagining a world where we're very low on the false positives, and we've also kind of fixed all of the assays so that by the time that there's detection, we know that we're going to be able to do something about it. And in that situation, again, like Otis mentioned, I really do see the opportunity to bring the healthcare system together. These are coming into primary care. And if you've ever had a cancer diagnosis and then tried to go back into primary care for something that you should be in primary care for, primary care doesn't have a high level of comfortability with cancer. And so as patients and as advocates, I think we need to help continue to elevate the understanding around health literacy, disease literacy, screening literacy, and then maybe also help the healthcare system kind of understand how to hold these patients, right? Because there needs to be a very clear process for an individual who does now have a positive screening for some level of cancer to get into that oncology roadmap. And if you've been paying attention, we are really struggling to have and to keep enough good oncologists in the space. And so, like Otis mentioned, we need to make sure that we're not creating better care for some and even more substandard care for other in that process.
Thank you. Stacey, from your advocacy work, what concerns do you most often hear from patients and advocates about multi-cancer screening tests?
I hear both big concerns and I hear wild excitement. And I think I'm more worried at this point about the wild excitement because people see a gap in screening for specific cancers especially, and they want this to fill that gap. From the population that's a little bit more kind of ready for it, but doesn't think that the tests are quite yet ready. Really what we're looking for is that a bit more standardization when it comes to sensitivity and specificity. These assays, depending on what company you're using, they're kind of all over the map, right? And they're also over the map with the sensitivity and specificity around specific cancers. So I think we're excited. We're very, very excited about the prospect, and we want to be able to embrace this when the time is ready. I think right now what we would like to see is more of these organizations engaging in dialogue with the advocacy community about what these tests are, where there are. We would love to help them in, the design of clinical trials that really help prove out the value of these tests. And then to those that are very, very excited, I'm never going to stand in the way of somebody trying to access a test for where there's no test, but I do advise people to use caution.
Yeah. My concern is, and by the way, when we both use the phrase or the word sensitivity and specificity, a highly specific test is very good at saying this person doesn't have cancer and they really don't have cancer. A highly sensitive test is very good at saying this person has cancer and they really do have cancer. And so we actually, in my world as a professional screener, we actually want something that's very high in specificity. We're less concerned about sensitivity, but we want very high specificity. Now, one thing that I'm worried about is Congress has this idea, as do many people in the United States. If it finds cancer and it finds cancer apparently early, it must be good. There's actually legislation out there to say that Medicare should pay for these things and bypass the FDA, who has the talent to say there's actual benefit from these things. The benefit is not it finds cancer early. The benefit is it finds cancer early and makes people live longer or makes people live a better quality of life.
I just want to clarify that the legislation that's out there is that I think a lot of groups are focused on is for Medicare to pay for it if it's been approved by FDA. So not it has to get that FDA approval, but I think we've talked about some of the challenges of that as well. So do you guys have any, we've had a great conversation. I didn't even really need to be here. I could have just sat back and let you guys talk. But I did ask a few of the questions from the audience and questions that I had. But thank you so much for your time. Do you have any final, we have like 1 minute left, if you have any final comments you want to make?
No, I really appreciate the forum for the dialogue. I really appreciate the sponsorship, and I would just encourage individuals to keep asking the questions, right? The problem is not solved, but it is a problem that needs to be solved, and it looks like, from my perspective, that we're not there yet, but we're well on our way.
And I just want to thank Stacey for joining me in this. This has been a lot of fun.
I knew you guys were going to have fun when we had our prep call and we got into the discussion. So thank you both very much for sharing your insights and for the wonderful discussion. And thank you to everybody for joining us and asking good questions and sticking with us for the full hour. So hope everybody has a wonderful day. And thank you again from NCCS.
Thank you. Bye-bye.
Thank you. Bye-bye.